I will take us through a case. This is a 5-month-old female who was delivered at term. She had a healthy neonatal period. However, at 1 month, the mother noticed a progressively enlarging right-sided flank mass with abdominal distension. This, the mother said, was preceded by 4 months history of excessive sweating. However, the child had normal bowel and micturition habits, and the birth weight was normal. So when we examined this child, she was alert, well nourished, and weighed 6.4 kilograms. She had no evidence of anemia, no evidence of jaundice or any palpable lymphadenopathy. The vitals were stable, the chest was clear, the heart sounds were okay. The significant findings we had on abdominal exam, there was mild distension and a non-tender right flank mass, which was measuring 15 by 12 centimeters. At that time, differentials included an infertile neuroblastoma, nephroblastoma, rhabdoid tumor or clear cell carcinoma of the kidney. So we did some labs, and the significant finding of from the blood that we were able to do was a raised LDH, and that is a tumor marker that can help us in prognostication of neuroblastomas. We did ultrasound scan of the abdomen, and there was mass in the right renal fossa. It was a solid mass, well defined with smooth walls, and appeared heterogeneous, as we can see on this image, with increased vascularity. So we went ahead and requested for a contrast-enhanced abdominal CT scan, which revealed retroperitoneal mass on the right side, ovoid, and appeared macroglobular. It appeared to be encasing the right kidney. The left kidney appeared normal, and this mass was crossing the midline with areas of focal calcifications and no evidence of the claw sign. So this baby was subjected to upfront nephrectomy because usually we do pre-op chemotherapy, but for this child, we went for surgery straight and removed an irregular multinodular well-circumscribed tumor from the right renal fossa. We sent this specimen for histology, and it turned out to be a neuroblastoma. And on sectioning the tumor, the pathologist actually noted that the kidney was encased within the specimen. So currently the child is undergoing adjuvant chemotherapy, and she's doing well. For us, the message we may have to take home from this patient is that the flank masses in infants, we have to think beyond the Wilms tumor. And for us, in our setting, ultrasound scan is a good screening tool to start with for children who have intra-abdominal masses. Thank you so much. We'll invite any questions. Over to you, Wijan.
Thank you so much, Dr. Aluka, for presenting this. Does anybody have any questions? Feel free to put them in the chat or feel free to unmute yourself.
I have a quick question for you, Dr. Luca. That was a really nice presentation. In general, especially with the second child who had this very, very large mass, and it's unclear what it is, and we'll talk a lot about it. Where, is your usual approach in other kids to start your neoadjuvant chemotherapy, start upfront chemotherapy in sort of thinking in terms of some of the PSYOP RTSG? Does it vary case by case? Does it depend on sort of resources in the area?
Yes, thank you, Dr. Lisa. Usually, we do the PSYOP approach, pre-op chemo, when the imaging is consistent with a localized renal tumor, and also the age group epidemiologically is suggestive of a Wilms tumor. Then we go ahead and treat them with pre-op chemotherapy. However, when there is any doubt, maybe based on the clinical picture or the imaging, we tend to want to do upfront surgery so that we have the histology to guide further chemotherapy.
Perfect. And if you had gotten in there and the resection was much more difficult, or things were much more encased, would you have done a biopsy? And
Yes, absolutely.
okay.
Yeah.
Okay, Felix here. Thank you, Dr. Luca. That's a really great presentation. Just to add on what Luca said, yeah, it is true. We tend to do the PSYOP approach because our patients really come late. However, we also have the challenge that we have other pressing issues more than the tumor. They come malnourished. We need to optimize them fast and improve their nutrition, things like that. So because of that, there are very few cases that can get an upfront surgery in our setting. Of course, like you mentioned, sometimes the children are really very little, like the case he has presented. You don't want to subject this little baby to chemo if you can. So those are some of the things that inform our decisions. Yeah, thank you.
Thank you.
Yeah, thank you, Dr. Luca, for the presentation. I had a question. One of the things we want to achieve through this kind of forums is raising more awareness to some of the global surgery needs out there. And, when I was in Uganda, I was often overwhelmed as to, there's so many areas of need. And you guys do so much with even the limited resources you have. In terms of this case, if you have to say one thing you wish you had, what is one thing you wish you had that could have improved or would have made the care delivery process easier or better for you, in your opinion? Just so that when folks are thinking about doing global surgery work, they know some areas of need that they can tackle ahead of time.
For this case, it turned out to be neuroblastoma, and I don't know how easy that would be, but from literature, I've seen other settings do other tests, have other imaging modalities, which I think Dr. Tracy will take us through. So for us here, the fact that we are limited to ultrasound and to the best CT scan, once in a while you can get an MRI. So it is still a challenge, and maybe it's the improved imaging modalities that beyond just a CT scan.
Thank you, sir.
Thank you, Dr. Eze. Dr. Luca has made it appear so easy that the CT scan can easily be got, but if he asked him personally, it wasn't easy to get a CT scan. As you know, Eze, you've been here before. So I would say, yeah, the case, probably you can hear the experiences of our colleagues in high-income countries. I think this child would have been investigated thoroughly and much better. But that's, I think, the best we could in our setting to achieve the treatment options that we had. Thank you.
Yeah. That's really great. That's really neat to hear. And it'll be interesting. We want to sort of talk a little bit about some approaches and imaging characteristics to differentiate some of the renal tumors, neuroblastoma, and then how those can inform surgical approach. And some of the caveats and things, but it all, of course, is context dependent. And in fact, the sort of general approach in terms of sequencing of chemotherapy and procedures can be very, very context dependent. So it's good to hear how things are and what some of the typical patient management is there. But I will let you then just let me know whenever you are ready for us to go with our presentation.
Yes, thank you so much, Dr. Tracy. Thank you, Dr. Aluka, for your presentation. Yes, feel free to begin whenever you're ready. We see your screen
Okay.
presentation, so that's perfect.
Yeah, I was trying. I did not know if it had successfully shared, so that's terrific. Well, I'm Lisa Tracy, and my partner in crime from radiology, who I'll introduce himself, is Joe Cow, and he and I have worked together for a while at Duke. I'm now over at UNC Children's. I'm also in the this Children's Oncology group, which is the North American sort of counterpart of PSYOP and the Renal Tumor Committee. And so I think a lot and think deeply about renal tumors. And what we are hoping to do is to give you a sort of an overview of renal tumors and approach to them, how imaging fits in and can intersect and can help plan your approach to the children clinically by finding out as much as you can about the tumors in order to guide what you do. And Joe, I'll let you say a few words too.
Hi, yeah. So I've seen a lot of you guys before. So my name is Joe Cow from Duke University, and had the pleasure of working with Lisa during her time here, and hopefully one day again in a few years. Yeah, imaging these kids is very complex, and oftentimes they do present late with us as well. So Lisa and I are very familiar with opening up a scan and just being very shocked at the extent of disease before they actually come to us. We do have the benefit of having more resources here, so CTs and MRs and ultrasounds are certainly more available. But nonetheless, I do strongly feel that CT is the mainstay imaging modality to work out both of these tumors, despite the availability of other imaging modalities. So you'll be seeing a lot of those on the presentation today.
Awesome. And so we wanted to start with just an overview and kind of what we're up to. So as you were saying, these abdominal masses in kids, many of these tumors, and especially Wilms, renal tumors in general, and neuroblastoma, will often start as painless abdominal masses. And not only in Uganda, but even in the United States, the most common presentation is of a painless abdominal mass that's palpable on physical exam. Often these get quite huge. And as everyone on the call is aware, it's, with parents, these things will just happen over time. And so it's actually hard for parents to notice the sort of small but growing change. Then when usually a relative or a pediatrician or someone sees them, it's pretty marked. Sometimes the parents will pick them up as well. But in that way, a lot of these can get very, very large before they come to clinical attention. Even over here, we see that as well, and it sounds like that's your experience as well. The most common abdominal masses in children are Wilms and neuroblastoma, as you know, and so that will be the majority of what you see. I can talk a little bit later about other renal tumors, non-Wilms renal tumors, which is a really interesting. But in general, they'll often, even though they're going to have some slightly different imaging characteristics, most of the time it will be, well, I have a renal tumor on imaging. Wilms and neuroblastoma, as alluded to in the presentation up front, are very different tumors with very different biology and behavior and very different prognosis. And that may be one argument for learning as much about them and sort of sorting things out up front in being really thoughtful about how you approach the kids. And again, most of the outcomes of these children were always humbled by as surgeons, where it is important. The surgery and how you do the surgery is an important part of therapy. The chemotherapy is an important part of therapy, but ultimately the biology maybe of the tumors may be one of the most important thing that's determining outcomes for these kids. So when you see an abdominal mass in an infant or a child, the next step is really, what is it? That's what family wants to know. That's really what you want to know in order to be able to approach it. Um, and for both Wilms and neuroblastoma, there are sort of urine and blood assays that can help you sort them out. And to the extent to which you have or don't have, the ability to do that at sort of the first place where the kids will come and present or in your referral centers, those can be helpful. But the imaging is going to be really what is the most informative in terms of diagnosing these masses. And some of the things that initial imaging can help assess, and some of the things that we'll kind of walk through and think about in the imaging are, one, just what is it? Two, what's the extent of the mass? What's really the stage of the mass? And how, and that becomes important for both approach to therapy, upfront therapy, versus the kids who come with masses that may be candidates for upfront surgery. And sort of what's going to be involved in their treatment. The other thing is, for some renal tumors, is upfront resection safe and or advisable? For many kids that, we can sort of talk about imaging findings that would make upfront resection either really technically challenging, and therefore likely not advisable unless there was some extenuating circumstance. And so other strategies like upfront chemotherapy or doing a biopsy for histology followed by upfront chemotherapy may be the path. And then imaging can help advise the considerations for the timing of surgery, but also how can what we learn off imaging make surgery as safe as possible. And so those are things that we want to sort of talk about. This audience knows, I think, a lot about the basics of neuroblastoma and of Wilms tumor. I just want to quickly go through some of the hallmarks of these two, and then which informs why it's really useful to sort them out by imaging. Wilms tumor, also known as nephroblastoma, is a renal mass, a primary renal mass in children. It really results from the failure of normal renal development and differentiation. It is most common in toddlers and preschoolers. 2/3 of kids are diagnosed before age 5. Most of the kids are in sort of the 2 to 4 range. There are renal tumors that are not Wilms tumors that, again, we can talk about later, but Wilms is by and large the most classic of the renal tumors. Presents as an asymptomatic mass, often picked up on physical exam, as we were talking about. And these can get very large before they're noted because the kids don't have very many systemic symptoms until they start to get symptoms just from the size and compression of the mass. The survival internationally and here in North America is really great for Wilms tumor. Favorable histology Wilms tumor is the treatment strategies that have been developed over kind of iterative studies on both the North American side by the Children's Oncology Group and and internationally through PSYOP. Different approaches, but both have really led to the needle for most kids with favorable histology Wilms tumor having excellent survival, which is one thing to keep in mind in Wilms. So the big challenge in Wilms, and one thing imaging can help identify, most kids will do great. There are some kids who have very favorable tumors who, as we were sort of discussing very briefly with the case presentation, who, if they had an upfront resection, might avoid chemotherapy. Those are the very low risk kids. And then it really depends on the international study group how you define them. In general, it's kids who have smaller tumors and who are young kids. On the next COG study, it'll be kids under 4 years old with favorable histology Wilms tumor will actually be candidates for avoiding adjuvant chemotherapy after an upfront resection. So that's one special group, are kids who might be able to avoid chemotherapy depending on the strategy. The majority of kids will, from a PSYOP strategy, be candidates for upfront therapy with significant reduction in the size of the tumor. And then these tumors tend to be amenable to resection, and we'll talk about why. And then there are the kids who have adverse biology in their Wilms tumor, who will need to have treatment intensified. And then there's some special cases of metastatic Wilms, either lungs or liver, and these or other sites. Extrapulmonary, meaning outside of the lungs, metastases in Wilms is pretty rare, but does happen. And so that's another consideration in terms of imaging and imaging beyond the kidney itself. Wilms tumors, from a surgical standpoint, often push structures. They displace, they don't encase. And I think that's a really useful concept. So they push more than they invade. They get really big, and some of the considerations around them really relate less to worrying about the vascular encasement, but more worrying about rupture. Wilms tumors can rupture preoperatively or can have an intratumor bleed. Sometimes these can be very significant bleeds. That's another sort of thing that we can sort of, from imaging, both the size and looking at either has this tumor ruptured or potential for preoperative rupture. Risk of rupture higher with tumors over 10 centimeters, risk of intraoperative spill of the tumor. So when we think about resection, some of these tumors, studies have shown that if they're over 10 centimeters, that increases the risk of intraoperative spill. So that's one argument for, in many of these, upfront chemotherapy in order to get a response from the tumor. In the United States, if we're going to do upfront chemotherapy of a Wilms tumor, we will almost always biopsy that tumor first. The PSYOP strategy is different, where upfront chemotherapy of a renal mass happens without a biopsy standardly. And so the timing of surgery, I think, one will be informed by imaging, but also really relates to the standard approach internationally through PSYOP would be a neoadjuvant therapy for a suspected Wilms tumor, renal tumor, and then resection. There may be exceptions for tumors that aren't responding, and the histology becoming important and the biopsy becoming important. In North America, it would be upfront nephrectomy as the standard, unless we think that we can't do that without spilling the tumor. And again, if in over 10 centimeters, we have to ask, do we think that this is going to be something that's amenable to an upfront nephrectomy? But in both groups, any tumors that have complicating factors like intravascular extension of the tumor, pulmonary metastases, or other sites of metastasis like the liver, we would all treat upfront with chemotherapy, with, as I was saying, the biopsy being the practice before pretreatment. in North America. Now, with that said, I want to distinguish Wilms or compare and contrast Wilms very quickly to neuroblastoma and go over a few of the basics and then talk about how in imaging we sort these two out and how we can really use imaging to help guide the best treatment for these kids. So for neuroblastoma, this is a tumor rising from neural crest cells, typically adrenal origin or retroperitoneum, but really anywhere along where these neural crest cells migrate to, including superior mediastinum along the sympathetic chain. They can be cervical. And they're again most commonly infants and toddlers. This is a very common tumor in kids ages 1 to 2. They can present as asymptomatic masses, which are picked up on physical exam or imaging, much like Wilms. However, kids who present with both the palpable mass and systemic symptoms, often weight loss, fever, hypertension, are more likely to have neuroblastoma. Some of the kids will end up presenting even quite sicker. Survival is really determined by biology, and in North America, on current protocols, runs about 50 to 60% for the high-risk kids, but that's through a very intensive therapy, multimodality therapy, and for intermediate risk can get as high as 90% as well. Neuroblastoma in cases. So if Wilms displaces means pushes things out of the way and just occupies space, neuroblastoma encases major vessels and becomes intimately associated with the vessels themselves. In fact, sometimes we have to, it is akin to almost scraping or sort of, coaxing the neuroblastoma off the vessels. Neuroblastoma will encase, it will compress, it's very adherent. The biology really determines a lot of the outcomes. And then the therapy for neuroblastoma is intensive and staged. For suspected neuroblastoma, often these are so large and they're such vascular encasement that most children are going to require a biopsy for histology and then upfront treatment with chemotherapy. The North American protocols will sequence chemotherapy, surgery, stem cell transplant, and then other treatment modalities. But the point is that really for many, especially of the adverse biology neuroblastomas, the treatment is very intense. And knowing the biology of the neuroblastoma also can help guide in terms of the completeness of the surgical resection. Neuroblastomas are notorious for a high risk of nerve injury, major vascular injury, and injury to adjacent structures. So with neuroblastoma, the imaging can not only help guide in terms of diagnosis and when to do surgery, but also can be extraordinarily helpful in figuring out what are going to be the technical considerations and the trouble spots during surgery and how to best prepare the child. So if there's one thing from sort of a imaging surgery correlate is that Wilms displaces a neuroblastoma in cases when we think about considerations and what we can learn from imaging. And with that, I'm going to let Dr. Cow start talking about ultrasound characteristics of both of these.
Sure, yeah. I guess at least I don't have control of your slides, but if you want to go forward, I can kind of describe the two. Unfortunately, for ultrasound, a lot of times you don't have great distinguishing characteristics of the tumor itself. The biggest hurdle that we run into is oftentimes when they present, they are so large that they take up the entire field of view in such a manner that it looks mostly like this component of this heterogeneous mass. This is a Wilms coming out of the kidney. So if my entire field of view is taken up by this, it was essentially indistinguishable from neuroblastoma. Wilms tumor is indistinguishable from neuroblastoma. The reason for that is because neuroblastoma and both Wilms and neuroblastoma can act very differently very similarly on ultrasound. They're both heterogeneous with these regions of hyperechoic tissue, internal hypoechogenicity, and large geographic regions of hypoechogenicity, and essentially. Essentially giving us a lot of headaches. So they all have internal vascularity because they're solid tumors, right? And because they can internally necrose, they can even have internal cystic components as well. Neuroblastomas tend to calcify. Wilms tumors, however, can also calcify. So because of that, there's a very limited distinguishing features on ultrasound. The biggest feature that I look for these when I'm looking at one of these with my sonographers and I'm going to scan myself is actually the normal kidney right here. If I can actually see a chunk of normal kidney wrapped around in a claw-like fashion, we call that the claw sign, right, around this tissue, then I'm highly suspecting that this is a Wilms tumor with the mass basically expanding out beyond the starting in the renal parenchyma, extending out beyond it. You can go to the next slide, Lisa. Next picture. So here's another one. And this is a good example of where I can't see the renal tissue, right? This is in the left upper quadrant. I don't see any kidney adjacent to it. This is essentially indistinguishable. You have internal flow here on Doppler. You have internal necrotic cystic components, internal heterogeneity, which is not really defined with bands of hyperechoic tissue. These bands of hyperechoic tissue. It's perhaps this is a chunk of kidney. I just can't see that very well because it's so far deep in the field of view. But this is an example of where our differential would essentially be both, and I would leave Dr. Tracy befuddled or having to order a CT because I'm likely the same way. You can go to the next slide, please. All right. So the great thing about neuroblastomas is sometimes they have perineoplastic syndromes, and we can catch them fairly early, right? They can present as a large mass encompassing the entire abdomen, but if we are lucky enough to get them early, they look very similar to Wilms, right? They're a well-described, circumscribed mass with internal heterogeneity, areas of internal hyper and hypoechoic lesions. The biggest thing is I can actually make out the kidney here on the side, and I can see that the kidney actually comes in and forms this acute angle right here with the adjacent mass. So this angle tells me that the neuroblastoma is actually more likely pushing down upon the superior margin of the kidney rather than directly coming from the kidney, and I'm much more likely to tell Dr. Tracy that this is more likely to be a neuroblastoma than it is than a Wilms tumor. All right.
Sorry. So, Dr. I don't know if you want to say more about ultrasound, or when you sort of at the, from a surgeon standpoint, you can learn a lot from ultrasound. And, you can even evaluate for intravascular extension, i.e. tumor thrombus of Wilms. But at some point, it's very nice if you have the luxury of having cross-sectional imaging to have cross-sectional imaging. And the reason is because you can understand the characteristics of the tumor a little better. It is a really nice sort of correlate for the anatomy and for looking at the extent. When I think about a CT scan, I'm really looking at both the characteristics, what the major vasculature doing. Is this an encasing sort of a tumor, or is this a displacing sort of a tumor? If I'm thinking if it's a Wilms, what's the size, and are there any other areas that this extends to that I need to be cognizant of? I want to make sure I have chest imaging. If it's a neuroblastoma, I really want to know what is encased to try to make a assessment of, is this a neuroblastoma that at all would be amenable to surgery, or if I'm going to biopsy, how can I biopsy safely and where should I biopsy? And then what considerations will look like, and what sort of how far down in terms of cycles of adjuvant therapy do I think I need to re-image the child in preparation for the ultimate surgery? And let me see if I can advance here. Some of the things for Wilms tumor, we really want to make sure too, contralateral kidney, we understand if it is involved or not. bilateral Wilms tumor or unilateral Wilms in a child with a predisposition syndrome, or if both from a SIOP and a COG standpoint, a very special case in terms of how we approach those, because we really need to prioritize renal sparing surgery to the extent possible. So we really want to know about this. Rupture, did it rupture preoperatively? That is going to make, even in the kids who will get an upfront resection with a pretty moderately sized Wilms tumor, if there was a preoperative rupture, a lot of us, even in North America, would consider pre-treatment, but also it's going to inform how sticky the field will be. When you have an intraoperative spill of Wilms tumor, it's often up sort of posteriorly and superiorly, where it's adherent to the diaphragm. And it typically is at the point in the case where you think that, everyone's excited, tumor's coming out, we've got the vasculature, we got everything, and then it's really getting that sort of superior posterior part that you can't really see well. We talked about intravascular extension and distance spread. In neuroblast, and then these are sort of the reasons, as we've talked about, that we really want to look carefully at those imaging studies, so that we will know what, either how to plan the surgery or how to sequence the treatment. And then ultimately, once we do plan surgery, typically with pre-treatment, the tumors have a nice response, but we still need to plan the surgery safely, because the intraoperative spillage can upstage a tumor, where we'll have tumor, that is beyond the renal capsule, and can have consequences for radiation fields, for the kids who are going to be getting radiation. Also sort of the completeness of surgery, including making sure that we understand if there is intravascular extension beyond the very proximal renal vein, that we know that and are prepared for that in surgery, with everything that the kid would need to make the surgery safe and be able to resect that intravascular extension of the tumor, or either plan for the child to be in a center that's prepared for more blood loss, if we need to be sort of controlling and opening the inferior vena cava, or in some cases, cardiopulmonary bypass, if we need to go higher, consider resection of part of the cava along with the tumor. And then, Joe, I'll let you talk about CT characteristics.
Sure, yeah. So I was also going to mention, we do Doppler analysis on ultrasound of both tumors when we see them. It's unfortunate oftentimes that our sonographers are so good that they can actually detect flow in a lot of these vessels, and when there is actually tumor in vein or tumor in somewhere, the kidney has a lot of times collateralized vessels, so that our sonographers are mistake due to the distorted anatomy. They mistake certain collateral veins for the presence of a patent renal vein. So due to those imaging pitfalls, we don't routinely comment on we don't examine this too closely in terms of like, is there a renal tumor in vein, unless it's a very obvious enhancing mass within a dilated vessel. And when we do suspect that, however, we will actually modify our protocol slightly to go look at the IVC, for example, right at the cavolateral junction, to see if there's any mass that's gone up into the IVC. And I think I have a CT case of that later. So Wilms tumor, like Dr. Tracy said, it tends to displace things out of the way. So this is a good example of clearly a palpable mass on CT, pushing all of the bowel out of the way, creating this nice margin of distorted peritoneum and omentum and bowel. The nice thing about this is on CT is you can actually see the normal renal parenchyma enhancing down here, and therefore it's coming out of the kidney. We're lucky in that our CTs come in multiple different slice thicknesses and very high spatial resolutions, and can be oriented in different ways, so we can track how much kidney is involved, and we'll obviously look at the other kidney as well. And when we reconstruct all the different spatial planes of our CTs, we're able to see whether the tumor has actually spilled out into the peritoneal cavity as well. This is a good example here, just of that degree of mass effect. All right. And so here's an example of where we are concerned about tumor in vein. So this is, again, a similar to Wilms tumor, pushing everything aside. The biggest thing you'll note here is that there is a dilated vascular structure here, as denoted by the arrow, and all of these dilated collaterals, vessels along the lateral margin of Gerota's fascia around the kidney. So these are collaterals that the abdomen, that the body has formed due to the occluded lower extremity return from the IVC. This actually goes up into the heart, and all the blood is coming back through the abdominal, these dilated vessels. So this is a good example of that. If we do see a tubular vascular structure somewhere near our Wilms tumor or near our abdominal mass, we'll ask the sonographers to go up and look at the cable-atrial junction to see how high it goes into the chest. All right, next slide. And here's an example. It is fairly uncommon, obviously, to have Wilms tumor metastases, but when they do, they look like cannonballs that have shot throughout the kidney. So there's multiple nodules throughout both lungs. There's probably a malignant associated effusion back here. These can happen. They often start small if they do happen, but if they progress and they're not intervened on, they can cause a malignant effusion. They can cause a malignant pericardial effusion as well. This is actually probably more likely to be reactive. But all these nodules are nonetheless very suspicious for metastases in the setting of a known cancer. All right, next slide. All right, there we go.
Sorry. And then for neuroblastoma, very similar. We're looking really at the extent of the tumor on cross-sectional imaging. We're looking at body cavities involved in the tumor. Remember, the neuroblastomas, they can be in the neck, they can be high up in the chest and the near the thoracic inlet. They can be along the sort of the posterior mediastinum. We can have dumbbell tumors that involve chest and abdomen. They can be in the abdomen, often pushing up from the retroperitoneum and sometimes elevating vessels, encasing. And they also can have involvement of bone and bone marrow. And so those are all things that we think about when we have the luxury of doing additional studies above and beyond CT abdomen, pelvis, such as a bone scan or MIBG. This can be really helpful in figuring out extent of the tumor. But just being aware that with neuroblastoma, there is the potential, even in what might look like a smaller, more localized neuroblastoma, there's the potential for marrow involvement. Is important. Obviously, that can be assessed off of bone marrow aspirates done at the time of biopsy or access placement as well. Image-defined risk factors. These help us stratify and stage these neuroblastomas. The image-defined risk factors really describe by anatomic compartment some of the considerations of the tumor that make them more tricky from a technical standpoint and would make upfront resection really sort of have an unnecessarily high morbidity when we know that initial neoadjuvant chemotherapy will help the tumor shrink in size and hopefully shrink back from some of these sort of high risk areas. But as you can see, for each of the compartments, there are very specific image-defined risk factors. In general, what they share is this idea of encasing a major vessel and compressing a vein. So for arteries, we look at the encasement and we look at the circumference of the artery that is encased by the neuroblastoma. Image-defined risk factors include partial encasement that's above 50% sort of circumference or total encasement, which speaks for itself. For veins, whenever we have veins that are completely compressed, that's an absolute image-defined risk factor. Some of the veins that just that abut but are not compressed by the neuroblastoma, or in often cases we're not sure if this is a neuroblastoma or a ganglioneuroma. that is not an image-defined risk factor. Also looking at what the relationship is with the nerve roots whenever the tumor is extending into the foramina. That's also a point where that's a risk factor itself. And then there you can see more of the specific image-defined risk factors. But that's a really important concept with neuroblastoma and is a concept that's often best sort of evaluated from cross-sectional imaging when available. And again, sort of a larger view of the neuroblastoma image-defined risk factors. And let Joe jump in to talk a little bit about what that actually looks like on real scale.
Great. Yeah. So this is a good example of, let's see, a neuroblastoma arising from the left adrenal gland. You can see it up here. It's distorting the superior margin of that kidney, pushing it down. So on CT, it's pretty confident to say, given the age of the patient and presentation and appearance here, that it's a neuroblastoma. The nice thing about it is, as Dr. Tracy showed, there's a lot of IDRF imaging-derived risk factors that involve vascular involvement and neuroforaminal involvement. This one is nicely encapsulated. The renal hilum is down here, and the renal vein is expected to cross at this level, going up to the IVC. So the nice thing is we have a lot of fat planes separating out this particular lesion from adjacent vessels. Left side being always easier because there's no porta hepatis over here, unless your liver is on the wrong side, for that involvement to occur either. All right, go to the next slide. Here's an example of neuroblastoma with internal calcifications. This is a little bit more tricky because we have to often reconstruct this to see exactly the extent of perihepatic extent and how much this is encasing the portal veins. Again, the renal pedicle is actually down here, so and the IVC goes up this way, so there's not a lot of involvement around the adjacent kidney. So we can go to the next slide. Here's a situation where the patient actually presented a little bit earlier. This is an example of neuroblastoma, and as we recall, as Dr. Tracy has mentioned, the neuroblastoma can happen anywhere along the sympathetic chain. That's why we have all these imaging-derived risk factors regarding carotid vessels and neuroforamina. This is one that actually presented right at the thoracic inlet, causing Horner syndrome. So therefore, it was clinically very apparent. We got the CT and found that image, and you can see there's actually tumor extent into these neuroforamina right here, these two compartments. So this is actually a little bit higher than what the technical IDRFs say, because those are at T9 to T12, but there's still concern there's enough concern to warrant additional imaging. For our setting here, we would probably get a spine MRI for something like that. And when you have an image like this, however, you know that it probably extends above the field of view. So because of that, you would want additional neck imaging to look at its actual involvement around the carotid vasculature. So we can go to the next slide. This is an example of the neuroblastoma, hitting back on Dr. Tracy's concept of neuroblastoma surrounds structures and encases structures rather than pushing them aside. This is the aorta here, and I will mention this is the one thing that I teach my residents about. This is that in pediatric patients, something elevating the aorta off of the spine up to here is very concerning for a neuroblastoma. So the only other entity that can do this in pediatric patients is a lymphoma. So if you have something coming out of in the retroperitoneum doing this to your aorta, this is a pretty big clue that it's a neuroblastoma. It has that same internal heterogeneity, and as you can imagine, it's distorted. It is now distorting all the vessels along the porta hepatis. You basically cannot see a kidney here. This actually extends pretty far down, involving the portal veins and the renal veins as well, and then completely encasing the aorta. All right. Here's a situation where it's actually abutting but not encasing the vessels. So this is the carotid right here, and this is the margin of our neuroblastoma. And if you window this correctly, and you can actually see and reformat it in different planes, you can actually see a small plane in between the carotid vessel. This is another case of a thoracic inlet neuroblastoma. And again, these image-derived risk factors are things we look at when we do CTs of the head and neck region for these things. All right, here's one that does actually abut. So this is the carotid vasculature right here, and this is the medial margin of that neuroblastoma. So you can see that it actually does abut the carotid artery as well, and it causes some mass effect on it. I think there's actually tissue coming around this side, so we'd have to reorient that. And this is the tricky situation where we have conversations in tumor board with Dr. Tracy and say like, well, do we think that's 48% in case involvement or actually greater than 50% involvement? And these are tricky challenges that we face here. Right. Similarly, encasing the renal veins. So here's the renal venous vasculature here, and you can tell there's actually a discrete cutoff of the veins, and that's because the mass has actually surrounded the renal vessels here. Luckily, there's a nice fat plane between the tumor and the liver, so you're not going to get any porta hepatis involvement. Right. Here's it is above the abutting, excuse me, abutting the portal vein. This is the portal vein. Sorry, this is windowed improperly, but this is the mass coming up along the inferior margin of the liver, and it's actually going to be abutting that portal vein. So, so yeah, this is a situation where it actually spared the renal vessels, but it abutted the porta hepatis. All right, and oh, here's the one with the liver met, the big liver. So they can present with metastases already. These metastases, especially if you do any nuclear medicine imaging on these, Dr. Tracy will know that these can behave poorly on MIBG imaging, so much so that they either get lost in the background liver uptake of MIBG, or they can actually become actually show decreased uptake in the liver, so much so that you miss it on initial scans. All right. And this is an example of our bone. These are the bony lesions that we look for. We basically survey the entire axial skeleton looking for these. And patients often present with initially mixed lucent and sclerotic lesions within the skeleton. The pitfall, the imaging pitfall here is pediatric bones have a lot of these mixed sclerotic areas that are normal. So having an experienced pediatric radiologist identify what is a normal sclerotic area versus an abnormal sclerotic area on the bone does get tricky. And that's why Dr. Tracy calls me. All right.
Yeah, absolutely. And with these either of the tumors, one of the questions that can come up too can be, what is the timing of repeat imaging? What's the necessity of repeat imaging after neoadjuvant chemotherapy? And how can we use neoadjuvant or reimaging to our advantage for surgical planning? Obviously, for tumors that receive upfront treatment, either a renal tumor without a biopsy or neuroblastoma, usually with a biopsy, we want to assess the response to therapy. Most renal tumors will be amenable and should be amenable after 2 cycles to have their local control surgery. However, there are cases, especially with intravascular extension of Wilms tumor, where chemotherapy may need to be intensified and an additional therapy done. So this could be a useful thing for the interval imaging. Neuroblastoma, at least for our North American protocols, there are sort of 2 windows in which we will assess the response to therapy. If at the first window it looks like the morbidity of the operation to remove the neuroblastoma would be greater than we think is reasonable from what we know about tumor biology and ultimate response, then we'll often give additional cycles. At some point, you're going to get diminishing returns, and then really it becomes more about planning a surgery, whatever that surgery is going to involve, and keeping, knowing enough to plan the surgery to maximize the patient's safety as well as to minimize the morbidity. So imaging can help us with understanding where risks are of major bleeding or hemorrhage, or for intravascular extension of Wilms tumor, if we're going to need to get vascular control, what points we'll need to get vascular control of large vessels like the IVC, what we'll need to, will we need to be opening up or resecting some major vessels? Will we need to be doing reconstruction? Will we need to be doing nerve monitoring? Cross-sectional imaging with contrast can delineate major vessels, and it's important to sort of communicate with the radiologist and know the capabilities of your radiologist in terms of being able to show you exactly what you need. If we're for, neuroblastomas that may be around the portal vein, for liver metastases, we may really want to understand sort of portal venous anatomy and hepatic vein. So the timing of the contrast. For other things, other neuroblastomas, it's very important to understand the arterial anatomy. And so what specific sequences we can get can be really helpful. Make sure on the cross-sectional imaging, pay attention to all the structures, including things like ureters in a neuroblastoma, to understand if you need to either know that they're going to be in the field and you just need to be careful, or if there's options for stenting or other ways of keeping the resection as safe as possible, whether you need to be prepared to deal with tumor extending into the neural foramina, whether that be by knowing the potential for it, or by involving sort of more of a multidisciplinary surgical team. And then one caveat, one thing I always say is that the structures you do not see on imaging, especially with the neuroblastoma, are as important as the ones you don't see. So when you're looking at a big retroperitoneal neuroblastoma and you're going through the different branches coming off the aorta that you would expect to see, and the different vessels and the cava coming through and the iliac veins, when you don't see that structure, that should be a red flag to you that structure is likely very encased / could be thrombosed or could be completely compressed by the tumor. And that's a really dangerous situation where you want to think about upfront how surgically you're going to be able to follow that vessel into the tumor, since you're not going to be able to find it in the tumor itself, especially in a neuroblastoma. I'll let sort of Dr. Cow, I think I had, yeah. This is an example of a neuroblastoma in the chest. I'll let you describe what you see, and then I wanted to sort of put a few sort of putting it all together slides up here.
Sure, yeah. Oftentimes we see these on radiograph first, as they distort the aortic stripe on chest X-ray. When we get the actual CT, we end up seeing something like this. You see the mass on the left lateral margin of the thoracic spine here. The thing to note is the most important thing is to reorient these so that you see if there's internal neuroforaminal extension of this tumor. And here it doesn't actually look like it within this image. I believe this one was actually spared. When you see something like this, neuroblastoma obviously comes up in our differential. However, the age of this presentation is oftentimes more important than what this tissue actually looks like. If I'm seeing an 11 or 12-year-old, an older kid with something like this, I'll think of a more differentiated neurogenic tumor. If I'm seeing it in a much younger child, the neuroblastoma is highly elevated on my differential list.
Great. And then with Dr. Cow able to tell me that much about the tumor up front, this is, one of the exceptions that proves the rule, which is with most neuroblastomas, it's going to be the morbidity of an upfront resection is pretty high. This was a child who actually, this was an active neuroblastoma, and which is how it came to clinical attention. And it was actually localized. It was, in the same kind of general neighborhood as the descending aorta, but not in any way associated with it, barely touching it. So this is something that's sort of amenable to a resection in a low stage tumor. But I wanted to put a caveat because this is a nice case and a nice example where this is a really small neuroblastoma, which I'll let Dr. Cow describe on imaging. But then when we did additional investigation of the marrow, there was extensive marrow involvement. Joe, I'll let you describe a little bit of
Yeah,
what you
sure. Yeah, I mean, I see this mass superior to the left kidney here, very well circumscribed and very little peripheral mesenteric stranding on here, and not causing a lot of regional mass effect, not surrounding the visible vascular structures. Good fat plane between the adjacent renal vein. Yeah, looks like a pretty straightforward, easy surgery for you.
That's right. This is what what surgeons might call a quote unquote tasty case. But the on and we had the luxury of doing PET on this child. But you can see that he had very extensive uptake in marrow spaces of the by or involvement by the tumor. And so for a child like this, and this is an interesting thought question, whether he should have upfront resection even of this localized mass, or whether he's better served by having starting on adjuvant chemotherapy, in part because he can start that more quickly if he's not having to heal a surgical wound, even though it's a pretty straightforward surgery. So it shows sort of a case demonstrating something that is more localized. Here it's nice because we don't have the dilemma about if it arises from the kidney or the adrenal, since it's pretty clear the kidney's down here. It's an adrenal mass, but even so, one where the imaging really helped us go down a road that we might not have otherwise gone down. Now, would it have been a mistake to resect it up front? No, it's a neuroblastoma. Do marrow aspirates hopefully at the same time and then find out there's marrow involvement? Not really. He would need to recover before initiation of chemotherapy. But it was nice to know this going into the case up front. Oh, that's a picture, intraoperative picture. And as you can see, it's a relatively straightforward case, but it's not without some risk, even though he had a relatively limited surgery and recovered pretty quickly. Um, and let's see. Um, Also, I wanted to just sort of also put in a book for the way the imaging can guide for anyone who, most of you have probably been involved in neuroblastoma resections, but when they encase the vessels, neuroblastoma, even well-differentiated ganglioneuromas, and you've given upfront treatment. The preoperative imaging can be such a nice roadmap because once you're inside, you end up seeing something like this, where you work for a while even to just find vessels that will lead you into a tumor. So it's really nice to have a preoperative roadmap in order to kind of ultimately clear the tumor and get something like this once you've gotten the tumor off and around from the vessels that it encases, and to do this safely. I also just wanted to mention very briefly the Wilms with intravascular extension. Um, Joe, you haven't seen these, but this is the majority of the infrahepatic cava on this child with Wilms tumor is you don't see flow. And I don't know, Joe, if you have any comments on this, but it's essentially from the level of the hepatic vein down to the iliacs, and I'll show a couple more images. Is where the tumor involvement is. But I wanted folks to be able to see some other images of extensive intravascular extension of Wilms tumor.
Yeah, this is an actually interesting case because I bet the primary tumor, from what I can see on the left kidney there in the inferior pole, seems relatively small. Unless there's another larger one hiding that I can't on another slice. But I bet this presented early because of this vascular involvement, because it's crawling up the veins and it's not exploded out of the kidney, taking up half the abdomen right now.
Yeah, and full disclosure too, this is after treatment too.
Oh, okay.
Yeah, this is unfortunately the intravascular extension did not improve.
Mm.
And I thought that this was a really neat image too, because now that we've got what is a more reasonably sized Wilms tumor here on the left. You look at this the image of the intravascular extension, or look where the cava should be, and they're from just after the iliac bifurcation up to the level of the hepatic veins. You can see that this is really still opacified. It's an interesting dilemma for surgical planning, because now we're at the point where we really do need to do local control. And so, options for this, I'll ask you, Joe, the can you talk a little bit about how to look for collateralization on these scans?
Sure, yeah. My biggest internal control is I try to look as far away as I can in the pelvis for let me draw for the vessels about this size down here, or perhaps this size around the bowel. Those are like your normal internal control of mesenteric vessels. So if we're I mean the intravascular extent we're already going to be seeing up here. So I'll have an internal guide of this is the down here's the size of vessels I'm expecting to see throughout the abdomen. And if I see larger ones in areas I don't normally see vessels, or especially around the liver, around the spleen, basically all of the blood flow is collateralizing going back up somehow back to the heart, right? So they're all going to be going coursing superiorly and finding small vessels that you normally don't see at all or are usually very small.
Yep. And that's important to know because preoperative planning for something like this, gives us options in terms of this is a really large portion to maintain vascular control of the vessel without, thinking through things like would we need suprahepatic control? Would we need to go to the chest? Would we need potential ECMO or bypass? But because we can see that there's been a lot of collateralization, this kid probably will tolerate clamping of this IVC and may even tolerate resection of the IVC, as both that right kidney should be well drained through collaterals as well as the child's abdominal viscera. Oh, and this is just an intraoperative picture of intravascular extension, what that tumor thrombus may look like whenever it comes to resection. You can see there in the lumen right in the middle of the picture a little bit of tumor thrombus. So another note that you can learn as much as you can by imaging and also confirm those intraoperatively with direct palpation. This obviously is not the kid before. Um, and then the one final thing I wanted to just show folks, extrapulmonary metastases in Wilms. So pulmonary metastases, I think people are familiar with. Extrapulmonary metastases are less usual in Wilms. This is an example of a right Wilms with a large hepatic extrapulmonary metastasis. I don't know, Joe, do you have any observations on this? I mostly put it in just to show that these happen and talk a little bit about surgical management.
Yeah, they're certainly very unusual. Infrequent, sorry, infrequent. But they definitely happen. The biggest thing that gives me pause if I see anything in the bones, my differential expands to not Wilms. So I don't ever underestimate Wilms and its ability to metastasize to other places except the bones.
Yep. And so this is another sort of view, and you can see how this is a really large extrapulmonary metastasis. And looking at this sort of with cross-sectional imaging, we can start to plan whether how you could resect that the hepatic metastasis, and can you do it safely, and can you and should you do it up front. This was a child who we chose to biopsy and pre-treat. I think that a PSYOP approach might be to have just started pre-treatment on this. And we had favorable histology Wilms tumor after our neoadjuvant chemotherapy. You can see the renal mass had a reasonable response. The extrapulmonary metastasis in the liver had a really nice response, and this is going to be a very doable liver resection, which we used a little bit of intraoperative localization with ICG in order to resect it, which is why you can see it glowing green when we put the right fluorescence light on it. But just an example of a hepatic metastasis from Wilms tumor, so that if you see that in the future. And then I think I'm going to avoid going through some of these other cases too much, but I wanted to also make sure that we have time for folks